Assistant Consultant, Pulmonology, Department of Respiratory and Sleep Medicine at Medanta. Dr. Swati has done her MBBS from Shri B.M. Patil Medical College and MD in Respiratory Medicine from SBKS Medical College, Gujarat. She has specialization and expertise in pulmonary critical care, bronchoscopy, allergic disorder, and immunotherapy, sleep-related disorders, pneumonia, TB, and other URTIs. She has expertise in the interstitial lungs disease and other COPD. She has a lot of publications also, like COVID, a fungal pneumonia. It is a case series. She has a publication, the parallelism in the diagnostic performance of bronchoscopic sampling techniques in lungs carcinoma. So, I request Dr. Amrita Swati, please come upon the dais for your valuable words for your lecture.
Thank you so much for your kind introduction. First of all, respected principals, respected dignitaries, faculties, and dear students, I would like to congratulate you all first for your 27th Foundation Day, 97th Foundation Day. And I am a pulmonologist, and today I had been asked to provide a lecture on any topic of liking, and I chose this topic, asthma and its mimickers. So the reason why I chose this topic is that asthma is the one of the most common pulmonary diseases we all see in the presenting in the outpatient department. And I wanted it to be a lecture mainly addressed, as I was told that post-graduation students will be attending this program. So I wanted this lecture to be mainly addressed towards the post-graduation students. So the slides are very basic. My idea of this talk is to mainly the slides are just to guide us through the talk, but my idea is to have mainly a one-to-one talk. Like I want you to interact with me, and I want you to raise your questions and your ideas. Because definitely it is like we are coming from different sides of medicine and standing here. So you have some different kind of understanding. I have some different kind of understanding. So I would like that I can also learn something from you, and I can put on my ideas on the table. And as it is more directed towards the research side, to inculcate research practices or research thoughts in PG students, I would really like you can interact with me anytime during the talk. If you have any questions, or if you have any suggestions, or if you have any ideas, you can interrupt me anytime and talk. And if someone can put a mic around with this audience so that they can put up their ideas in between. So it will be really helpful because these points will help us go into the think about the what are the research potential.
नहीं नहीं ठीक है ठीक है
So coming to asthma, what is asthma? So asthma is basically an expiratory airflow limitation. The definition of asthma is provided by GINA Association 2020. GINA 2023 definition is what I'm talking about. So what is GINA? GINA is a global initiative for asthma. It is a committee formed in the mainly it contains dignitaries, consultants, practitioners from many countries. But they come together and they give a practice guidelines every year. GINA provides a practice guidelines every year for the management of asthma. So talking about GINA 2023, so they define asthma as a disease which is heterogeneous. So there are some keywords about the definition. So why is it called a heterogeneous disease? So it is a heterogeneous disease because it doesn't present in the same fashion in every patient. Every patient of asthma will have a different kind of symptoms and presentations within a spectrum. Definitely. Like asthma, some patients of asthma can have cough variant asthma. They will present with predominant symptom of cough. While some patients in asthma will have more symptoms of breathlessness, wheezing, nocturnal symptoms, and all those things. Some patients of asthma can present with other associated symptoms like other associated involvement like allergic rhinitis, or they can have atopic dermatitis. Maybe something is involving the nose as well, the eyes as well, the skin as well. So it is not a rule that every patient will have all the symptoms, but so that's why it is called a heterogeneous disease. Now, what is the second point? The second point is it is variable. That means asthma is not same always. Like if you get a patient with any other chronic illness like hypertension, and or if we compare diabetes, so a hypertensive patient, if not on medication, will have hypertension. A hypertensive patient, if a diabetic patient, if not on medication, will have raised blood sugar, will have those symptoms of polyuria, polydipsia, and all those things. But an asthmatic patient, it is a variable disease. That means sometimes it will be there, sometimes the patient might feel normal. Why? Because asthma is mainly caused by some kind of environmental trigger or some kind of allergen which predisposes, or in predisposed individuals it leads to exacerbations or manifesto of symptoms. So that is the third point in the GMA definition, that is a variable disease. It occurs in response to some known or known stimulus or precipitating factor, and it is reversible with treatment. So, comparing asthma with other obstructive diseases, asthma is a reversible kind of disease. That means if we give treatment with inhaled corticosteroids or whatever treatment are the treatment lines of asthma, the symptoms usually get rapidly reversed. Okay. Now, coming to what are the environmental factors and what are the triggers in asthma. So, there are certain things which are called as environmental factors. That means those factors predispose for the development of asthma. And then there are some common triggers in asthma. So, what are the environmental factors like change in weather, cold? Those are the environmental factors. But cold by itself doesn't lead to development of hypersensitivity, doesn't lead to airway remodeling and asthma. Cold precipitates. It leads to such environment that where the triggers are like dust, the house dust mite, pets, pet exposures, some pollutant dust, all those things are triggers of asthma. So this is just a common, showing all the common triggers like tobacco smoke, pets, mold, cleaning products, pests, and air pollution. So all these things by itself are not harmful. But this in conjunction with some environmental factors like even like exercise can be an environmental factor. So this in conjunction with an environmental factor leads to the development of asthma. Now, coming to what basically happens in asthma. So we are here talking about the pathophysiology of the asthma. So when we see the structure of lungs, so when we see the structure of lungs, we are seeing that this is the airway. These are terminally dividing airways, and we have two lungs, which is the parenchyma. So when studying the diseases of the respiratory system, we divide the diseases into main three strata. One is airway disorders, then there are parenchymal disorders, then there are interstitial disorders. Right. So the disorders which mainly affect the airways, the conducting pathway from where the air goes into the lungs until it reaches the alveoli, where we have exchange pathway. Okay. So the diseases involving the airways are, yes, please. You raise your hand. No. Okay. So the diseases involving the airways, the conducting pathways, are called airway disorders. Then comes the alveoli, where the actual exchange of gases occur. So the diseases involving the alveoli are called as parenchymal disorders. So we all are oriented with the same anatomy. So the alveoli are like the lobules, and the terminal bronchiole goes and divides, and then we have multiple lobules, and the alveoli consists of the parenchyma. And then the exchange gas traverses to the interstitium. That means there are blood vessels in the interstitium which carry the gas, and then they go back to the heart, and then it is delivered, the oxygen is delivered to the whole system. So the diseases involving that thin interstitial layer are called interstitial disease. That much is clear. So asthma is predominantly, or asthma is only an airway disorder. So why asthma is an airway disorder? Asthma is basically occurs in response to inhalant allergens, some proteins, some kind of antigens which are there, which come and settle in the our airway is directly exposed to the outer environment. So that those come in direct contact with the airway, the inhalant and allergens, and from there the inflammation starts. That's why it is mainly predominantly an airway disorder. If the same allergen they go beyond the airway, you can say that why alveoli is not exposed to the environment, it is also exposed to the environment. The air we are breathing goes up till the alveoli also. So some allergens which are even minuscule, much more smaller in size, much less than 5 microns, which can even get carried away beyond the distal airways and goes up to the alveoli, they can lead to by some different mechanism, they can also lead to allergic disorders, and that is a different kind of allergic entity, and that is called as hypersensitivity pneumonitis. So, asthma and hypersensitivity pneumonitis are two diseases of allergic origin but have very varied presentation. So, today we are focusing towards the asthma. That is that. So, what happens in asthma is that these are the airways. It is dividing and branching here, and somewhere here you can see here where it goes and divides into the terminal bronchiole. So, this is the picture of the terminal bronchiole. So what happens grossly here we are seeing, we'll see at microscopic level, at cellular level in the next few slides. But in grossly what we are seeing, what happens is that these terminal bronchioles there is inflammation. So these swellings are representative of the inflammation. So we know that the terminal bronchioles, the structure is that there is mucosa, submucosa, there is muscularis mucosa, and then there is external. So there is inflammation in the submucosa, and this is the muscle layer, smooth muscle layer surrounding the bronchus, and there is constriction of this smooth muscle layers. So this inflammation and this constriction, these both together lead to narrowing of the airway. And asthma mainly involves the distal airways. Distal airways means not the central, not the trachea, not the main large bronchi. It mainly involves the distal airways, which are the terminal, secondary, and tertiary generation of the airways. Okay, so this is what basically happens there, that the lining of the mucosa gets inflamed, and the muscle there is bronchoconstriction in response to the allergen. So this leads to narrowing of the airway. So you can see this is the caliber of the normal airway. Here the air exchange can occur easily, and here we are seeing the cross section. There is the mucosal layer is there, submucosal layer is there, and then muscularis mucosal layer is there, where there is a smooth muscle cells are there. So when in asthma, what happens? This opening gets narrowed. This is the main pathophysiology in asthma. That this opening gets narrowed. Why it gets narrowed? In exposure to allergens and inflammatory response. So this the thickness of this muscular submucosal layer increases because of the increased vascularity, increased a collection of cells, inflammatory cells here, and then these muscle layer, this constricts and this further leads to narrowing. So this narrowing, what does it causes? It causes decreased exchange of gases, and that goes back to the definition, what we discussed in the GINA definition, that there is expiratory airflow limitation. So whenever there will be narrowing, the airflow will be limited. If the opening comes down, if the opening narrows, the flow will get limited, and this limited airflow is what produces the symptoms in asthma, which produces the common symptoms like breathlessness, wheezing. All these symptoms are due to this airway narrowing. Now, this is another diagram which shows the same thing what we discussed. This is the normal airway, this is the normal mucosal layer, submucosal layer, muscular mucosal layer, and here there is mucosal hypertrophy. So, kind of a chronic inflammatory response is going on. Now, if this lumen, if this airway gets persistently stimulated, persistently inflamed, and there is no relief or no treatment, so chronically what happens, that eventually after repeated inflammation, repeated injury, there will be hypertrophy of the mucosa in response to the repeated antigen what is presenting here. There will be hypertrophy of this mucosa. There will be increased vascularity. This is the vessel. These are the vessels, submucosal vessels. So increased vascularity, hypertrophy of the mucosa, and the mucosa contains some goblet cells as well. So there will be increased production of mucus. So here there is minimal mucus here, somewhere thin layer of mucus is there, but here there is quite increased production of mucus. This complete is mucus. So sometimes there is productive cough as well. And these are the neutrophils and eosinophils. Collection of the pink cells are the eosinophils, the trilobar cells are the neutrophils. So there is increased collection of the neutrophils, eosinophils. Even the hypertrophy of the muscular layer is also seen, that the smooth muscle layer has increased in number. So these are all the changes of chronic asthma. Now, so as I told, this is a very busy slide. Don't go into much detail in it, but I'll just put out in and I'll try to simplify it and put out in an easy way. So here we are seeing the cellular mechanism behind the asthma. What happens at cellular level? Why all those changes what we were seeing inside the airway? Why there is increased production of mucus? What happens when an antigen comes in contact? So let's say that there are multiple things which our body is coming in contact with every day. Our body is as good as something present in the outside, a rotten leaf lying on the floor. How it is interacting with the nature, how it is interacting with the environment. In the same way, our body is also interacting with the environment. Which every area which is exposed, our skin is interacting with the environment all the time. And similarly, our respiratory tract is also in contact with the environment. So when it is in contact with the environment, a lot of things come in contact, like there are pollutants, there are bacteria, viruses, allergens, and everything. So what are allergens? So anything that is foreign to our body is considered as an allergen by our immune system. Now, anything, just see that if there is a room like this, anybody who comes from outside has to register on the table that I am this person, identify me, I am this person, and then that person goes and sits inside or it can move outside. So, similarly, anything which comes in contact with our body at the mucosal level has to register itself, has to identify itself. I am this person. I am harmful or not harmful, or my immune system decides that. So, seeing that these bacteria, these viruses, these are harmful. They can produce diseases. They can manifest diseases. But these allergens, these are innocuous substances. They do not manifest any diseases. But in some genetically predisposed individuals, they can not they have higher sensitivity to these things, and then they start reacting to these allergens. They do not identify allergens as potentially non-harmful substances, and then they start reacting to the allergens in the same, thinking that they are harmful substances. In the same way they should have reacted to some bacteria or viruses, right? So this happens in genetically predisposed individuals, in patients with hyper-responsiveness, in some kind of gene-environment interaction goes on here. Okay. So when these allergens come, they this is the epithelial mucosal epithelial layer which we have seen. This is the cut section of the respiratory airway mucosa. Okay, so this is the mucosal epithelial layer, and this whole area is the submucosa. Whatever is going on in the submucosa. So we have as we know that bone marrow and lymph nodes are the houses of the immune system. The immune cells are mainly housed in the bone marrow and lymph nodes. And from bone marrow, this certain kind of T cells, the T and B cells, which are the main immune cells. So certain kind of T cells, they come out from the bone marrow and then they mature and become dendritic cells. Why is it called dendritic? There is multiple, so many half pairs. This is for dendritic cells. Yeah. So there are multiple tentacles it has. This is called dendritic cells. So the cell which resides in the airway epithelium, which mainly does this job of catching everybody foreign. You are foreign. Okay, let me catch you and find it out whether you are harmful or not harmful. So that cell is called as dendritic cell. It is kind of a macrophage. Okay, so this dendritic cell comes to the mucosa and then it catches everything, all these allergens. And similarly, this same cell, it also identifies the bacteria and viruses via multiple chemokines and cytokines. You don't have to remember all these names of these chemokines. So this mature dendritic cell has comes in contact with the allergen, takes the allergen inside the cell by phagocytosis, and then processes it. And the most important part of the protein, whatever it wants to present, it presents it on the epitopes, which is called as MHC complex. It presents it via the MHC complex. And then these dendritic cells, they take it to the lymph node, the nearest lymph node, whatever lymph nodes. We have multiple lymph nodes, the lymphatics drain into the lymph nodes. We have multiple lymph nodes in the thoracic region, we have subsegmental lymph nodes, we have hilar lymph nodes, we have mediastinal lymph nodes. So it homes to the nearest lymph node where it tells them, where it informs them. So lymph node is another center for immune system, which is the office of the immune system, local office. This is the central office, this is the local office of the immune system. So here the dendritic cell catches the allergen, says that I don't know you, let me take you to my head office, my regional office. So in the regional office, it presents the antigen to the T cells. So the T cells are like inspectors. So these are TNEs, naive T cells. These are new T cells. They don't know, they don't have any specificity towards anybody. They don't have any liking or any dislike. So these naive T cells, they have all the memory. They have all the data from behind that what is my self antigen. Whatever antigens are there in our body, they know them that these things are my self antigen. My muscle protein is self antigen. My collagen protein is self antigen. So it identifies it as something as non-self. It is something from outside. So T cell will mature against this particular antigen and form Th2 cell. So this happens for any kind of antigenic stimulus that comes in our body. It happens in normal individuals also. This process still here. It happens in normal individuals also. But we have Th2 differentiated Th2 cells for almost all kind of allergens. But everybody doesn't manifest as much. Everybody here, it stops and this Th2 cells here, it understands that this kind of stimulus is non-harmful. Okay, so here they have some genes are there which are responsible for identifying that this kind of protein structure is not harmful for me and this kind of protein structure is harmful for me. So if you're genetically predisposed and you're not able to identify that this kind of protein structure is harmful or not harmful for me, then further downstream chain of event goes on. So now this mature T cells which has identified this antigen will come out in the mucosa and it will lead to production of some specific markers which are called as immunoglobulin E, IgE. Okay, so this IgE is the marker which we test in our blood. So here is where IgE comes from. So this mature T cells will go into the mucosa, it will home in the mucosa, and if it produces specific IgE to that antigen. So that IgE will have some structural facets where specifically this allergen and this antigen will come and bind. So that IgE will be released. Now those IgE will come and bind to we have some cells in the mucosa called as mast cells. Those IgE will come and bind to the mast cells, and the mast cells will keep wandering everywhere. It will be there in under our skin. It will be there under our nose, nasal mucosa. It will be there in our airway. It will be there in our eyes. Everywhere. It will be there in the blood, and wherever it will find something to bind. Whenever that allergen comes, that IgE linked mast cells, they will be ready. They will have 5-10 IgE antibodies linked to it, and that beautiful mast cell will be ready to catch that antigen whenever it comes. Now it has labeled it as something foreign, something harmful, and as soon as that antigen comes, that IgE will go and bind it. And immediately after binding, what it will cause? It will degranulate. That means it will take out all its weapons and it will release histamine and serotonin and all these preformed mediators. And this histamine is what leads to the manifestation of asthma by bronchospasm, by acute bronchospasm, by itching. Histamine causes itching, and then coughing, and all those symptoms of rhinorrhea, sneezing, all those things are then downstream caused by release of histamine. So I have directly skipped to treatment part, but so in between I would like to discuss some things like, so what happens after this? So now we have read that what asthma is by definition, what happens in the pathophysiology. Now what happens after this? After this, the patient, when or the let's say the individual has been sensitized once. The allergen has come, it has been registered. Now the body, the person who is predisposed to develop asthma, the body has told that come on, have your guards up. I can, if this antigen comes again, then we have to fight with it. So that person is called a sensitized individual. That individual is still not asthmatic. That individual is only sensitized. Now again, what this sensitized individual will present as? Now this sensitized individual in combination with the environmental factors. So whenever the environmental factors in association with the triggers will come, then this patient will manifest symptoms. So what are the environmental factors? Like we discussed, exercise can be environmental factor, climate conditions can be environmental factor, temperature can be environmental factors. All those environmental factors in association with triggers. So what can be triggers? Like smoke can be a trigger for asthma, pollutants can be a trigger, molds can be a trigger, fungal exposure, dust can be a trigger, pets can be a trigger. So these triggers and environmental factors, when they come in play together, then that can lead to the symptoms of asthma. So when many a times we have seen, or if some people are here who are asthmatic or who have experienced somebody in their families who are asthmatic, that they express symptoms only. Some people are who express symptoms at one place. Like I was living outside for few years. There I was having no symptoms, but when since I have come to this place, now I am having symptoms of breathlessness. Why? So because the environmental factors have changed, some pollens have changed, something that was there at your previous place is not there here, or something that is not there, you were used to it, but something new is there here, for which you are producing symptoms. So those things happen. Some patients might have, or some people might experience that I get symptoms only twice a year, and then rest of the year I'm fine. I'm totally fine the rest of the year. Why this happens? Is because it is not a constant disease. It is not a something which happens all the time. This is allergen. If the allergen loads are higher, then you might have more symptoms. So you are feeling that you are asymptomatic the rest of the time, and you are symptomatic for only few months of the years or few days, like that. So coming to the management part of asthma, so the this year the GINA has revised the management a lot. I mainly, for my practical understanding and my practice, it is in lines with GINA, but I, for my comfort, divide the management into main four pillars. First is controller therapy. Controller therapy is something which helps to control the symptoms of asthma. It is a baseline. Just think of it as something that is there as a baseline, which maintains the baseline, and then something is there which helps us in between. That is the reliever therapy. So we have controller therapy and reliever therapy. These are the two main pillars in managing the symptoms of the asthma. Whenever the asthmatic patient comes, and if we have to give the patient relief, if we have to relieve the symptoms of the asthma, these are the two main lines of treatment. So in controller therapy, we have inhaled corticosteroid and beta agonists. What are inhaled corticosteroids? Inhaled corticosteroids are drugs like for budesonide, cyclosonide, fluticasone. These are corticosteroids. That means hydrocortisone is produced. Cortisol is produced in our body. They are derivatives of that. They work in the same fashion, but they are prepared in inhalational form. So, in today's era, the treatment of asthma is mainly by inhaled route. So, like, if I have to say 10, 20 years or some 25 years ago, there were some tablets available, like theoasthelin, or those tablets are there. But nowadays, all those things have gone, and we have mainly switched to inhalational route. Why? Because respiratory is a unique system where we have its own way of drug delivery. So when we talk about drug delivery methods, we have either oral route, we have injectable parenteral route, we have sublingual route. All those are different routes of drug delivery. So, but whichever route we choose, we have to choose the route which is most easily accessible, most easily administrable, and having least side effects. So respiratory is a unique system in that way that other than like apart from cardiac and renal system where you have to give through oral or parenteral route. So the medicine has to go through GI and then has to go in the blood system, and then via the blood system the medicine reaches the specific system. But in respiratory we have this large airway and respiratory epithelial layer where we can directly administer the drug, and the drug gets directly absorbed from the airway itself and has to act at the airway. So it is a drug at the local site. So for that reason, the treatment of asthma or treatment of many respiratory diseases has had a paradigm shift. We don't need to give the drug to the blood, so we can give the drug in much lesser concentrations because the drug is directly going to the respiratory system. For other things, we are giving the drug which is being absorbed in plasma in the blood, and then it has to maintain that much high concentration because the blood is distributed throughout the whole body. But here, the respiratory epithelium is confined to the respiratory system itself. So we can give much lesser amount of drug, and that can give us direct benefits at the same place where we are administering the drugs. So that is what is about this inhaled agents. So we have, and then there are many classes of drugs. Like in parental route, we have many different classes. Similarly, those classes of drugs which we can make the particle size small enough for inhalation. So we have different classes like corticosteroids, which I've already talked about, beta agonists, long-acting antimuscarinic agents. Then we have methylxanthines. These last three are oral drugs: methylxanthine, montelukast, and levocetirizine. Those drugs are yet not available in inhalational route, so they are being given orally. But the main drugs which we have in asthma are these inhaled corticosteroids and beta agonists. And then we have an on add-on therapy option. We have antimuscarinic. So what do these drugs do? So going back to the pathology, what had happened. So the inhaled corticosteroids, what are corticosteroids? There are anti-inflammatory drugs. That means wherever inflammation is going on, corticosteroids will try to bring down the inflammation. Okay, there are many other effects also which can lead to some undesirable effects, but that is why what I'm talking about is inhalational agents. These inhalational agents will have much lesser undesirable effects because they are not going into the bloodstream. The absorption from here, the drug will directly be deposited here, and from here it will directly act at this place. So from here, getting absorbed and going to the systemic circulation is as much as minimal. So the side effects of the corticosteroids has been reduced to practically nil by using the drugs in inhalational agents. So here the this inflammation which increased recruitment of cells, and because of this increased recruitment of cells, hyperplasia of the mucosa and this increased mucus secretion is there. For these things, the corticosteroids will act. It will directly inhibit the all the these cellular mediators was what we were seeing. All these cellular mediators, which are calling all different kinds of cells, these cellular mediators will call the eosinophils and neutrophils into the mucosa and will lead to further inflammation. So corticosteroids will cut down all these pathways. And it will cut down this pathway at the universal level. It will cut down the recruitment of dendritic cells. It will cut down the release of these cytokines. All these things will be cut down, and directly any inflammation, whatever is going on, will be decreased by the corticosteroids. Now coming to beta agonists, where do beta agonists act? Beta agonists act at this level. These beta agonists will help to release the bronchospasm by relaxing the muscular layer, relaxing the muscle. So the second most important component of asthma was bronchospasm. That is the muscle contraction. So beta agonist will help to relax the muscle contraction. So whenever beta agonist is, so mainstay of treatment is inhaled corticosteroid. What will decrease the inflammation is inhaled corticosteroids, while what will give instant relief of symptoms, or what will give relief of symptoms, is the beta agonist. So the beta agonist will directly come and relax the smooth muscles and will lead to ultimately increase the patency of the airway, and the patent airway will help relieve the symptoms of that. So these are the two drugs. LAMA, long-acting antimuscarinics like tiotropium bromide, like glycopyrronium. These drugs will again also help in decreasing the mucosal secretions, as well as they will relax the smooth muscles. So it helps in both ways. Then we have methylxanthines. Montelukast and levocetirizine are mainly anti-allergic drugs. They will inhibit release of histamine. So while discussing the pathophysiology, we had discussed that there are mast cells degranulation release histamine. So these things will help. Montelukast is a mast cell stabilizer. It helps decrease the release of histamine from mast cells. Similarly, levocetirizine, it blocks the downstream action of histamine. So histamine again will cause a lot of histamine itself will cause some symptoms, and then it will call all other people also. Come, eosinophils, you also come, like that. It will call many cells. So mast cell, the levocetirizine will cut down all those mechanisms. So like that, all these are controller therapy. Now coming to reliever therapy, what is the basic idea behind reliever therapy? Is that whenever am I short of time? So what is the basic idea behind the reliever therapy? Is that if the patient is on controller medication. But asthma being a variable disease, what will happen that I am, if suppose I am asthmatic, I am taking my inhalational medication as prescribed twice a day, but I have gone to some place or suddenly the season has changed. I have gone to some place where there was increased allergen exposure. Then still I can develop asthma. It is not a sure shot that okay, if I am taking inhaled corticosteroid, my whole genetics has been altered. No, it is not like that. These are controllers. They will only control up to a certain level. But they will control the symptoms, but the underlying mechanism is still working. My body still thinks that something foreign is an allergen and it has to be attacked. So again, if the allergen exposure increases, then the symptoms might increase. So at that time, what we have to do? At that time, we prescribe this reliever therapy. So we have to give our patient an option that if you develop some symptoms in between, if you develop increased symptoms, what you have to do that time you can take these. You have these options. So there is something called as asthma action plan. So we write and give on our prescription a complete action plan for the patient. How you have to monitor your symptoms, how you have to know that you are having increased symptoms, how you have to know that you are worsening in your conditions, and when you need reliever therapy, and how much reliever therapy you are needing, which would help you understand that whether you are landing in an exacerbation or when you should go up or come down on the treatment. So, what is AIR is a new term given by Gina this year, is anti-inflammatory reliever. So, what we have seen the two main drugs which we have inhaled corticosteroid and beta agonists. So, what beta agonists do that they release the bronchospasm, they relax the smooth muscle there. So earlier in our reliever therapy, we were only using beta agonists. Okay, so whenever there is acute spasm, release it by the beta agonist. Okay, but from this year, Gina is emphasizing that use inhaled corticosteroid also in reliever therapy. So every time the patient is having increased bronchospasm, give inhaled corticosteroid also in the reliever therapy. Inhaled corticosteroid is going on in controller therapy, but it is added in reliever as well. So AIR is anti-inflammatory reliever. So anti-inflammatory component is ICS and reliever is SABA. SABA is also beta agonist, it is short-acting beta agonist. LABA here, the controller, we give long-acting beta agonist. SABA, it is short-acting like salbutamol. Sometimes formoterol is also used. Formoterol is long-acting, 6 to 12 hours, but it is also used. So if formoterol is being used, it is called as maintenance and reliever therapy. ICS is inhaled corticosteroid and formoterol. So if formoterol is medium length, like we have vilanterol, which is ultra long acting, so which is like 24 hours, so can give only once daily dosing. Formoterol is medium length, so it is like 6 to 12 hours. The effect of formoterol will be there, so we can give it in twice daily dosing also. So what is the concept behind MART is single inhaler. So the patient has to, the compliance is better. Patient has to carry only one inhaler. Whatever the patient has, the patient can take 2 pumps daily for controller, and whenever there is increase in symptoms, the same inhaler, there is no confusion. Which one I have to take, which one I have to carry. There is no confusion. The single inhaler the patient can use as reliever therapy because formoterol is in between. So we can use it as short-acting action. It has very quick onset of action. What is the main concept behind reliever is that there should be quick onset of action. Whenever patient has acute spasm, then you would have seen in many movies or some serials or something that they show whenever there is acute spasm, patient just shakes the pump, takes 2 puffs. So why? Because they want instant relief. So at that time we have to give something which is fast acting. So formoterol has very quick onset of action, like within 1 to 2 minutes it has onset of action. So formoterol that is the unique thing about. Other than formoterol, we have many other molecules like salmeterol is there, vilanterol is there, but all those things are long acting but have slower onset of action. Like they will take 20 minutes to 30 minutes to start acting. So those things cannot be used as relievers. So only ICS formoterol combination can be used as both controller and reliever. Otherwise, we have in short acting we have this thing salbutamol. Then in ICS combinations in short acting we usually use budesonide. Cyclosamide and fluticasone are more used in once daily dosing, and they are more used in controller therapy. There is budesonide and there is beclomethasone. These two drugs are mainly being used in reliever therapy. Now coming to disease modifying therapy. So till now what we have talked about is controlling. Whatever is happening, whatever is already going on, mucus production has already occurred, bronchospasm has already occurred. Now let us control it. But here till now we have not addressed the underlying process. Whatever was happening, why this was happening, we have not addressed. Nothing. We have only addressed this part, what was happening here. But why this part is happening? This whole fiasco, this whole thing we have not addressed. Okay, so to target those things, I consider these options as disease modifying therapy. That means they have the potential to modify. Like I have borrowed this term from rheumatoid arthritis, where we have a specific class of drugs called as DMARDs, disease modified anti-rheumatic agents. So I borrowed that term for asthma, and I call them disease modifying therapy. Why? Because these are the options which inherently decrease the tendency of inflammation, of producing inflammation. So we have some biologics like omalizumab or mepolizumab. So while talking about the pathophysiology of asthma, I was talking about IgE. So IgE is the main culprit. So asthma has various subtypes. Some are Th2 subtypes, some are Th. Whatever immune cells are involved, according to that, we have various subtypes. So, but the Th2 subtype, the allergic subtype, is the main, forms the main chunk of asthma. Other are in smaller percentage. So, if you have say 100 patients of asthma, some good 60 to 70% of patients will be in the allergic subtype. Okay. So in that allergic subtype, what happens that the Th2 cells, the Th2 cells which we had seen in the lymph node from the local office Th2 people, they will go on and they will direct production of IgE antibodies. Those IgE antibodies will keep circulating in the blood. Now what this omalizumab does, it is an anti-IgE antibody. So it binds with the IgE and neutralizes it. So this therapy, sorry. So this therapy here, omalizumab, it directly acts on the pathway itself. So from the pathway, it will decrease the IgE levels, and it will actually not lead to decrease in IgE level, but it will neutralize the IgE antibody, and hence downstream, whatever is the production of inflammation, recruitment of inflammatory cells, mast cell, release of histamines, all those things will come down. So IgE and mepolizumab. So these are the biologics which act at the cellular level. At the microscopic. Yes, correct. At the cellular and chemical pathway level of asthma, and they have the potential to target the actual pathology what is happening in the asthma. Then similarly, mepolizumab is anti-IL-5. IL-5 is also a cytokine. Ig is an antibody, and IL-5 is a cytokine which is involved in recruitment of eosinophils. So ultimately, these IgE they will call eosinophils, and then all the eosinophilic symptoms will manifest. So mepolizumab blocks the recruitment of eosinophils in the airway, and hence leads to decreased airway inflammation. And the third modality, what I am discussing here, is allergen immunotherapy. So this is another. This is not like biologics. This is another unique modality in asthma, which uses the concept of desensitization. Now, what is desensitization? It uses the concept that if you have allergy to say one particular thing, like I will take a very common example, like cockroach. If some patient is allergic to cockroach protein. So we know that all biological or microorganisms or all organisms are made up of proteinaceous structure. So cockroach also has some kind of proteins in its exoskeleton. Some proteins are there in cockroach feces. So those proteins get airborne, and then they can, along with the house dust, it can get into the respiratory. We can inhale it. It is present in the air around us, and we can inhale it, and it can lead to allergic manifestation. So this protein, if I am getting newly exposed to it, I am not used to it, my body will consider it as foreign, and it will lead to increased symptoms. So symptoms of all that inflammatory cascade will happen, and then there will be symptoms. Now, allergen immunotherapy, what it does is it takes very small quantity of those proteins which you are allergic against, and then we start administrating it in gradually increasing amounts in very small fashion. So like 1,000th of the concentration of the protein will be taken. If you are allergic to 1,000 of the concentration, 1/10,000th of the concentration of the that protein will be taken, and it will be administered to you. The same protein which you are allergic against, but in a very small quantity. So now, in this much small quantity will not be able to initiate any inflammatory response, but it will tell the body that it is there present. So gradually, the body, the immune system gets used to it. By gradual exposure, by gradual continuous exposure to the allergen, the immune system gets used to it. Okay, it is coming to me daily. It is not causing me any problem. Then again, you will that injection will be given again after 1 week. Then again, those antigens will come in a very minuscule amount, like 1 to 10,000. If you're reacting at 1 to 10, then the 1 to 10,000 will be the concentration what is being administered. Now again, that 1 to 10,000 doesn't have the potential to produce disease. Doesn't have the potential to produce so much inflammation that you will get symptoms, but it will train the immune system that this is not something which is harmful for me. So this thing is not harmful. And gradually, those Th2 cells which were acting previously against the same allergen will be downregulated. The immune system is being trained against that allergen, and the immune system is being trained. Okay, this is not foreign, this is non harmful. Don't waste your energy on this. Go fight some other microbe which is actually harmful. Okay. So another theory behind all these allergic diseases is we call it hygiene theory. So earlier, hygiene was not as prevalent as in today's like earlier. What should I say? Hygiene was something which is for privileged, not for common man. Okay, so as we started being more hygienic, started living in more closed environments, traveling in AC cars, going to AC halls, and then coming, sitting in AC offices, coming back in AC, not getting interacted with environment at all. That also increases our propensity to develop allergic diseases. So this hygiene theory that maintaining extra hygiene, washing hands a lot. So all this hygiene theory, what it does, it decreases the exposure to allergens. And all these things which were usual to us, the dust which was usual to us, the different kind of proteins which was earlier usual to us, has now become new. And the same things which are not eliciting any allergic response in our previous generations are now eliciting allergic responses in us. So that is the concept here, that why if we are allergic to something and if we keep on continuously exposing ourselves to that thing, gradually the level of allergy will come down. So that is how. So it basically targets the main idea behind the allergy. It targets at the genetic level, that why this body is seeing this substance as an allergenic substance. It changes that mentality itself. So there will be nothing downstream. There will be the Th2 cell will itself be downregulated. So there will be no Ig production. There will be no mast cell, no degranulation. So you wouldn't need to treat with inhaled corticosteroids. Or rather, I should say that the patient wouldn't come off inhaled corticosteroids, but the need for inhaled corticosteroids would definitely come down. Okay. Now, moving to, and the fourth most important pillar is prevention. So in asthma, it is also as equally important to prevent exposure as it is equally important to take medication. So if you are going on taking medications and going on playing with your pet, if you are allergic to cat, you are allergic to cat, you have to prevent the exposures. If you are going on take two puffs and then play with the cat, there is no meaning. You're going on increasing the allergen load. If you are allergic to dust, if you are allergic to some particular thing, if you feel that I'm allergic to house dust, that dust which is comes off the carpet, I'm allergic to that, then you have to remove the carpet, remove the soap. That you cannot keep on brooming the carpet and then say I'm allergic, I'll go and take medication. So prevention is also equally important. So what can we do? There are multiple, according to each allergen, whoever is allergic to whatever, there are multiple ways to prevent it, but the main is avoidance of allergen exposure. Then prevention of further exacerbations. So what are exacerbations? Whenever there is increase in symptoms in asthma, that is called an exacerbation. So one can prevent exacerbation by complying to the controller and reliever medications. If you have decreased symptoms but still you are not taking medications, getting off medications, that would lead to increased risk of exacerbations. Awareness of symptoms, patient education is very important in preventing exacerbations and worsening of diseases. And lastly, vaccination. Vaccination against pneumococcal, vaccination against influenza is important in patients with chronic lung disease. Now, whenever a patient of asthma comes for treatment, we have in follow-up. So that was first when we have seen the patient for the first time. We were doing all those things. Now, whenever the patient comes back, I have to review that whether the patient has is doing all those things, whether it is taking all those medications. Then I have to reassess the patient and then adjust. So asthma is not a constant disease. It is a variable disease. So and every visit you have to review, assess, and adjust. Adjusting is the important. Adjusting means go up if the patient is having more symptoms. Come down if the patient is having less symptoms. Educate the patient how to go up and how to come down. Okay. Uh, so now coming to the next important part, what are asthma mimics? So as a patient comes, most commonly patient will come to a respiratory OPD or to a general OPD with respiratory symptoms. Will tell cough, खांसी है, खांसी हुआ है, 2 महीने से हो रहा है, 3 महीने से हो रहा है. Patient will not come and tell asthma. Okay, but then we go on. So खांसी, सांस फूलना, it can be linked with all respiratory diseases. How we come down from infectious to non-infectious or from malignancy to non-malignancy? That we have certain set of questions. We ask whether you have fever, whether you are producing a lot of yellowish sputum, whether you are having any chest pain. All those things help us cut down to infectious or non-infectious. Now, suppose we have come down to non-infectious, we are thinking, okay, this person is having cough and it is not associated with fever, there is no hemopsis, there is no bloody sputum, so it can be, probably, it can be asthma. So, what are the confounders? Now, what we have to think about, what are the conditions which mimic asthma? So, vocal cord dysfunction is the most common condition which mimics asthma. What happens? We have a larynx. When we speak, there are two vocal cords which move like this. Some patients have vocal cord dysfunction. What happens that the vocal cords get adducted, that means they close spontaneously while talking, and because they are sitting at the top of trachea, if the vocal cords close, they are not able to breathe. So they will come and tell breathlessness. This patient will not be relieved by any amount of beta agonist, any amount of bronchodilators you give. Why? Because the pathology is not in the lungs. The pathology is in the vocal cord. This vocal cord dysfunction is mostly related with some functional kind of disorder where there is associated anxiety or panic disorder. So you have to train them. Like there are speech therapists, there are swallow therapists. Those patients they need to go in physical counseling and physical training and counseling. So that we have to rule out that it is not vocal cord dysfunction. Then GERD, gastroesophageal reflux disease. That means patients with dyspepsia, they have a small amount of acid reflux will be there from the stomach, and that acid reflux can also cause breathlessness. That small amount of acid reflux, microscopic amount of acid reflux that trickles into the airway and then initiates breathlessness. So GERD that mainly will be managed by proton pump inhibitors. You have to use drugs like rabeprazole, pantoprazole, ranitidine. All those drugs will work here. So the main way of differentiating these things from asthma is mainly by history and by lack of features in support of asthma. So in history, if you have nocturnal symptoms, if you have seasonal variations, if you have associated symptoms of running nose or ear discharge, like ear itching, throat itching, all those things which are collaborative of an allergic disease or there is family history of asthma. So those things will help you determine, will take you towards asthma. If it is, and then you have investigations like you have pulmonary function test in which you test the capacity of the lungs. You check whether the lung capacity is improving after giving drugs or not. So if it improves on the test, what we do pulmonary function test, then it is indicative of asthma. If those things are coming negative and still the patient is having breathlessness, we can think of these causes. Then there is foreign body. Anytime if the patient is eating something, accidental ingestion of something in the respiratory tract, if it goes, it will produce the similar symptoms. It will cause wheezing because there will be airflow, there will be blockage of the conducting system. So it will cause wheezing, and it can mimic as asthma. And actually, very interestingly, recently we had a patient. She was around middle age, 50 years. Until then, she was never symptomatic. So asthma commonly presents, not as a rule, but commonly presents in the. It starts in the teenage, or it would present early in 20s or 30s. It's present. If somebody at 50s or for late 40s or 50s comes with symptoms of asthma, your antenna should go up. With, no, I have to think about some other causes. So this lady, she had come with history of wheezing and breathlessness. And she's saying it started just few months back. Now she has been already treated with since last 1 year. She was going around and she had been already treated with by 3-4 doctors in view of asthma. Why? Because everyone will put a stress and we are obese. So if there is a wheeze, it is collaborating with asthma. And when you do a pulmonary function test, there it will show obstruction. A pulmonary function test can, what results it gives? It tells us whether there is any obstruction in the airway or there is restriction in the air, in the lungs. Okay. So the pulmonary function test is showing obstruction. You are getting a good wheeze. You are getting, then she was being treated with ICS LABA or inhaled corticosteroid and beta agonists. Now that patient was having some relief but not complete relief. So she's going on saying, I'm having recurrent cough, I'm having dry cough, and I'm having breathlessness, and I'm having wheeze. Okay, so we went ahead and we had this doubt that why this thing is not getting resolved with. She has a typical PFT, she has typical symptoms, but why this thing is not getting resolved? And she didn't give any other history at that time. We got a CT scan done, and in that CT scan, we are seeing in the right side, the trachea divides into two. The right side, there is a small lesion, or something is there in the right main bronchoscopy. Then we asked her, did you ever ingest anything accidentally? Then she is telling that, yeah, 1 year ago when I was eating chicken, I accidentally a chicken bone went inside and I had a lot of coughing. Then why didn't you tell this? She's saying, why? Because since then I have visited so many doctors and everybody used to laugh at me that what you are saying that you have taken directly chicken bone, people will take sometimes fish bone will get stuck or something. No, that is not important. So out of shy, she had not shared that history, but that was a very important part of the history. And then we did a bronchoscopy and removed that chicken bone via bronchoscopy. And after that, she was completely fine. Like she came back to our OPD and she had no need for any medication. Nothing. She was totally fine. All that wheeze had disappeared and she was as good as normal. So that is how it was. It was not wrong. It was a mimic of asthma. Okay, so that is how it mimics. So foreign body post-viral tussles. After viral illness, all the airway, like even after COVID, you would have seen many people landed up with chronic cough. Or like everyone here would have experienced viral illness some or the other time. You would have seen बुखार तो ठीक हो गया एक हफ्ते में खांसी रह गई है खांसी क्यों हो रही है बुखार तो ठीक हो गया वायरल इन्फेक्शन तो ठीक हो गया एक हफ्ते दवाई ले ली डॉक्टर साहब अब खांसी रह रही है इसका क्या करें so what do you have to do? You don't have to prescribe any antibiotics at that time. It is simply increased hyper-responsiveness of the airways after viral infection. When viral infection is there, all those are acting through the similar cytokines are there in the previous picture which we had seen, the bacteria, virus and allergens. So similar cytokines are there. So after viral infection, all those cytokines are still there in the airway. They have still, the inflammation hasn't subsided yet. That's why even though virus has gone out of your system, that inflammation is still persisting and that is causing this cough. So this is not something new or this is not some worsening of the symptoms that मेरा viral खांसी तो ठीक ही नहीं हो रहा ऐसा नहीं है. That is a different entity and the post-viral tussle is also managed in almost a similar fashion. That they can give a small, short course of oral corticosteroid, a very short course, like 1 week course over tapering doses. You can taper it until 3 days, and then that brings down the inflammation. Then hyperventilation somatic conversion is also very common in young children, like in the middle school age group, 7 to 10 years, 12 years, like that. It is mostly linked with anxiety disorders. There are many variants of this. One is in which the child hyperventilates a lot. Another one is habit cough syndrome, where the child keeps on coughing. So these things are of the origin of the they are of rather somatic origin than organic origin. So there is no problem in the area when you do the PFT, all those things come normal. But because of habitual kind of thing, it is mainly addressed by counseling and psychotherapy. Then COPD, chronic obstructive pulmonary disease, is also mimic of asthma, but COPD has many differentiators, and it is definitely as differentiating between asthma and COPD is the main cornerstone of the treatment because then from after that the treatment will vary a lot. So COPD will have history of exposure to noxious chemicals like smoke exposure or smoking or biomass fuel exposure like that. Some working in polluted areas. These days, air pollution is causing COPD also. So is also causing COPD. So COPD will have many differentiators. In your PFT also there will be no variation. COPD will have constant symptoms. So COPD patient will always have symptoms throughout the year, while an asthma patient will have many dips and highs and lows. That's how you can mimic. And there are many more diseases I can include. I can include TB here, I can include ILDs, but I've just to keep it simplified and restricted to the airway disorders. What can mimic that? Any questions? Rather a long talk from my side, so I would like you to participate. Tell your thoughts. Anything?
Ma'am, please sit on the in front of the phone, please. Any question from the PG scholars? Yes, Amin.
डॉक्टर लोग ना आपने कहा कि एक्सरसाइज में एनवायरमेंटल फैक्टर हो सकता है कैसे ना
What happens is there is an entity called as exercise-induced asthma. So when a person exercises, the chances of developing all these inflammatory responses it increases. Like even thunderstorm can also increase the chances of developing asthma. So what happens in that is that normally if you are exposed to same cold air, you don't develop any symptoms. But while exercising, the airway hyperresponsiveness increases. The amount of air you breathe in increases. Tidal volume we say the amount of air you breathe in and we breathe out in a single cycle. That is the tidal volume. So the tidal volume increases during exercise, and during exercise also the adrenergic system it gets hyper responsive. So at that time, if the patient has tendency to develop asthma, exercising will act as a trigger. Exercising will so at that time during exercise, if the patient inhales cold air or if the patient inhales some pollens, some allergens, that can cause reflex bronchospasm. While the same allergens, same pollens will not cause reflex bronchospasm at resting state. So how we differentiate it from other kind of asthma is that if typically there is history of worsening of symptoms after exercising. Like the patient has any patient with asthma will have difficulty in exercising if not controlled. If controlled adequately controlled on inhalers, there is Usain Bolt who is running marathon with asthma. Okay, so any person who has not good control will have symptoms on exercising. But if a person has no symptoms before, no symptoms during exercise, but half an hour after exercise starts developing symptoms, that is classical example of exercise induced.
Thank you, Nana. What's the role of genetic factor? How much does it affect to the
So asthma, the pathophysiology is the term point for it is gene-environment interaction. So only genetic factors don't work. Like if you, but it has a strong, it gives a strong predisposition. So if in a family there is history of asthma in grandmother, there is history of asthma in mother, and three siblings are there. So all the three siblings will not develop the same kind of asthmatic symptoms. It is not necessary that all three will develop. While if you take for example other genetic diseases like thalassemia or sickle cell anemia, all the three siblings will have the genes. Whether somebody will be major or minor, whether someone will have one gene or both, but all will have the genes for asthma. But in thalassemia. But in asthma, what happens? Not every sibling will manifest the similar symptoms. Even if the same person is there, there has to be an interaction with the environment also. There has to be the genetic makeup predisposes, while the environmental factors they trigger. The environment brings in the trigger, and the combination of these two leads to development of asthma. So definitely there is a genetic component. If there is strong history of asthma in father and mother, the child has much more higher risk of developing asthma, and all the precautions should be taken right from the prenatal phase to decrease the chances of having asthma in that child, which are like exclusive breastfeeding, normal delivery over cesarean should be preferred. All those things are proven to decrease the chances of developing asthma in adulthood.
thank you, ma'am.
Any more questions? Ma'am, there is a question by my side.
Yes.
There is a myth that Asthma medications are habit forming and lose their effectiveness over time.
Yeah. So is it so? That's what the question is, right? So what are the asthma medications? What we discussed, those are inhaled corticosteroids and beta agonists. So that is why this question comes in the minds of asthmatic patients. I don't come across with patients who have hypertension or who have diabetes asking me, "Madam, आदत तो नहीं लग जाएगी sugar की दवाई की?" They don't ask. Why? Because it is a persistent disease. They know that this taking this medication is only helping me. If I don't take this medication, I will have increased BP and I will have all those symptoms of palpitation or swelling in feet or headache or increased whatever is associated with all those things. Okay. So asthma being a variable disease, it gives some kind of fear in the patient that if I take medication, why should I take medication when I am normal? And that is where this fear comes in that मुझे आदत तो नहीं लग जाएगी इसकी मतलब patient feels कि I am normal, then why is the doctor asking me to take this medicine? But what happens in asthma, as we have seen, there was airway inflammation and mucosa. So if you think this is the lumen of the airway, there will be some kind of basal inflammation and it will be at this place. Till here, our God has made such a huge reserve in our lungs that the patient will not feel breathless at all. We breathe at a tidal volume of approximately 450 to 500 and referencing an adult male of the height of 6 feet. So if females on a shorter height have tidal volume even lower than that. But at a reference tidal volume, adult male 6 feet height will have an approximate tidal volume of 500 to 550. Now, what is the total lung capacity? It is around 1500. तो 1.5 गुना है, कहाँ फर्क पड़ेगा? इतना bronchoconstriction हो भी गया तो पेशेंट को नहीं फर्क पड़ेगा. तो patient doesn't get to know that they are having underlying inflammation, but they are not symptomatic. And when the bronchoconstriction comes to this level, it closes up completely. At that time, the wheeze starts appearing. At that time, the patient starts developing breathlessness. And this doesn't, if this bronchoconstriction doesn't mean that each and every airway is constricted. There are some which are patent, there are some which are constricted. The patent airway is still doing their job. But when it is closing up to this much, say 30% or 40% of the airways are closed up to this much, now the patient is feeling breathless. Now the patient thinks, okay, I should take medication. Ask the lega. 1 week के बाद the patient will come at this level and again will become symptom free. But what we don't want the patient to keep at this level. Why? Because if the patient goes on at this level for a very long time, but we have seen the chronic inflammatory changes will come in and you could have also read this concept of acute and chronic inflammation. So when we have acute inflammation, we have neutrophils and eosinophils. Acute inflammation is reversible. But when it goes on beyond 3 months or after a very long time, it converts into chronic inflammation. That means these acute cells will go away to fight bacteria and viruses, and the chronic cells will come into picture like B cells and T cells, and fibroblasts will come and they will cause fibrosis. So eventually what will happen if the chronic inflammation keeps on going, this much area of the lungs will get fibrous. Now at this place, if we give whatever amount of inhaled corticosteroid we want to give, whatever amount of beta agonist if we give, this will not go back to normal. So the airway caliber will remain at a reduced level of 50%. So this is what is the goal of treatment in asthma, that we want to make it as good as normal. And if you are as good as normal, you can do everything. So asthma patients have the tendency to mask their symptoms. They will, okay, I have breathlessness on walking. I get sometimes breathless on climbing upstairs, but I'm totally fine on walking. Then why are you bearing with that symptom? No, because I will develop habit of this drug. So this drug is not habit. The habit is tolerance of symptoms. And why is it bad? Because it can go on now. 20 years, 30 years of age, you have very good lung capacity, 3 times of your normal required, so you can manage now. But with age, the lung capacity also goes down, lungs start degrading with age, and when you reach the age of 40 or 50, that time you are so breathless, and by that time the chronic inflammation has taken place over 10 or 20 years, and now the medications are also not. So we don't want that to happen. So the medications are not habit forming. There is no habit forming potential like you have with benzodiazepine, clonazepam, or you have with opioids, morphine, fentanyl. Those medications have habit forming potential. These medications do not have habit forming potential. You can bring down, you can decrease the medication anytime you want. only that it should be directed according to symptom control. During symptoms, being breathless and not taking medication is not a good idea at all. Always have a good exercise capacity कि दो बैग उठा के दौड़ के ट्रेन भी पकड़नी पड़े तो पकड़ लें. ऐसा नहीं कि चलते चलते ही ट्रेन पकड़ेंगे. So good, there should be good exercise capacity. And when you ask these patients who takes medications in between, when they stop their medication, when you ask, do you have good exercise capacity in between you? Can you walk with? Can you take a bag and walk flight of stairs? No. Why? You will need to travel by a bus. You will need to. You won't always. Not every average Indian travels by air all the time. And if you travel by air, you have to take your bag off the conveyor belt at that time also. So you should have exercise capacity. That is the main thing, and that is the target of asthma. That it should be as good as normal. So asthmatics can live as good as normal, as good as any other individual without any exercise limitation, provided that you take medications, that they take medications properly, and the dose of medication should be targeted according to the symptoms. If the symptom burden is high, then the dose should go. If the symptom burden is low, then the dose comes down. And that is what we discussed in that reassess, review, and adjust. So what are we adjusting? We are adjusting the medication, the dose according to the symptom burden.
Good afternoon. My question is, like diabetic patients, some patients have symptoms of palpitations also with some other underlying causes. And in that patients, when we give like some kind of asthmatic attacks are there, and we are giving nebulizations, and nebulization like salbutamol or Puricor. These causes hyperpalpitation and the patient goes in tachycardia. And so at that time we use some other alternatives. And likewise when you're using tablets like clofazimine, these are beta agonists. And mostly the medications which you already told us, all those are like beta agonists and it causes palpitation more in patients like that. So at that time, how do you adjust the patient to those tablets? Like one of the patients was using Unicontin E, that is theophylline, and every time she uses that, and she's saying that she's getting more severe to that symptoms of palpitation, and she gets weakness and all those things. So how do we manage that, or we should give some other medications for them?
That is a very good question. That is a very practical problem which we face every day. So all these drugs, mainly in concern with diabetic and hypertensive individuals and patients who have cardiac comorbidities and are diabetic. So as you talked about diabetes first, I'll just quickly go through that point. So diabetics have what the problem is increased blood sugar. Our medications, the side effects of increased blood sugar is the risk with systemic corticosteroids. So here, instead of systemic corticosteroids, we go with inhaled corticosteroids. Inhaled corticosteroids have minimal systemic absorption. So if we have to give systemic corticosteroids, say in the event of acute exacerbation, where injectable hydrocortisone or injectable methylprednisolone is given for acute relief of symptom, acute control. So at that time in diabetics, you can monitor the blood sugar level. That is usually done in inpatient setting. So at that time, you can monitor blood sugar level and switch the patient to insulin. So because why we are switching to systemic corticosteroids? Because acute exacerbation, like status asthmaticus was the previous term which was fine, but now we call it severe exacerbation of asthma. That is a potentially life-threatening condition. So in that potentially life-threatening condition, where there is hypoxemia, injectable corticosteroids are indicated. So there we are giving it as a life-saving measure. Okay, so that time we can manage. We can always increase the dose of insulin and manage hyperglycemia. So that is the concern in diabetics. And in the outpatient setting, when the patient is stable, now if you are discharging the patient, you can switch to oral corticosteroids, or you can switch to inhaled corticosteroids. So if you have given systemic corticosteroids, you gradually taper down the steroids. You don't cut it off completely. So when you're switching to oral corticosteroids, keep the OHAs. If the patient is on OHA, if the patient is on injectable insulin, whatever, keep it on a little higher dose. And just warn the patient that you have 1 week course of oral corticosteroids. So keep on monitoring your blood sugar at home. Okay. And after that, when the patient comes on follow-up, you can gradually switch to inhaled corticosteroids. Inhaled corticosteroids practically are not absorbed, and there are many studies suggesting that they don't cause fluctuation in sugar levels. That is concerning to hyperglycemia. Now coming to the second part of the question, palpitations, tremors, and arrhythmias, right? So that is a very tricky place how to deal with it. So all these in medications, our short beta agonists, our methylxanthines, and our antimuscarinics also, they increase heart rate. So they cause tachycardia. And beta agonist will cause stimulation of the adrenergic system, will cause tachycardia. Antimuscarinics will decrease parasympathetic system, will cause tachycardia. And similarly, methylxanthines are also have cardiac side effects, like they predispose the patient to arrhythmias. So what to do in that situation? So again, I'll divide in IP and OP. In inpatient setting, what we do is we keep them on monitored. They are in monitored setting. Take an ECG. If there is no arrhythmia, whichever problem is predominating, first address that problem. If the patient has come to me in acute, and this is more so common in COPD than in asthma. Asthmatics are usually young age people, so they don't have a lot of comorbidities. So I will give the opinion as a common thing. Whichever patient you are taking. If you are taking in the patient has cardiac comorbidities also, and that patient will have to relieve the bronchospasm. I will see the baseline, what is the cardiac function status of this patient. If the patient's baseline heart rate is well in the normal limits, like 60s to 70s, I'm very much happy with it. I will go on and take the benefit of giving beta agonist, short-acting beta agonist and long-acting beta agonist as well. In the hospital setting, we usually use formoterol or levosalbutamol. These are the two beta agonists we are using in hospital setting, which we have twice daily dosing. And with levosalbutamol, we have a lot of flexibility. We can give it 4 to 5 times. We can give it for acute relief of symptoms also. Now, if the same patient is having tachycardia, I would rather come down on my beta agonist. I will not try to give as much beta agonist. I can take the help of this thing, injectable corticosteroids here to relieve some amount of bronchospasm. So I will start the patient on IV hydrocortisone or IV methylprednisolone also to help me decrease the bronchospasm. I'll continue with the inhaled corticosteroids. And at the same time, for rate control, I can use other drugs like ivabradine, I can use like metoprolol, I can use, which metoprolol will again cause bronchospasm also, so there is a fine balance which we have to attain. So those drugs I can use to decrease to control the heart rate, and I can bring an equilibrium. So this is very common thing which happens, especially in mainly in patients with COPD, because of changes of port pulmonale, they are more prone to having arrhythmia. So the only trick is to balance. You have these drugs, we use these drugs. I would avoid using methylxanthines. I would avoid using injection deriphyllin in all these patients. I will try to, because methylxanthines are even more notorious. That is called, they have very narrow therapeutic index. That means in very small range of dosing is there, which is safe for the patient, and it varies for every patient. And in India, we don't have the luxury of monitoring the drug levels. When we don't have that we can measure serum drug level कितना है, वो सब luxury नहीं है अभी हमारे पास. So we try to avoid methylxanthines in these patients unless nothing else is working. So in that case, control the heart rate with some heart rate control medications like ivabradine or even metoprolol. Some patients which are even more difficult, we have even used digoxin to control the heart rate. But having said that, those things are not simple, not as easy as to be said and to be given. There are a lot of monitoring involved in all those things, daily ECG or twice daily ECG, blood level monitoring of electrolytes, all those things have to be done. And you have to rule out all other causes of arrhythmia, like it is not heart block, it is not due to MI. So for the rhythm changes, you have to understand that it is the basic cardiac side should also be okay. It is only tachycardia or it is some other cause of heart block. So if there is some other cause, that has to be addressed. If there is associated diastolic heart failure, that has to be addressed by diuretics and all those things. So like that, it is a fine balance tuning mechanism. So it is not that you have some other drugs to use, you have these drugs to use, but you balance it with other drugs and you try to use it in a judicious way as much as is required and is not harmful for the patient. Coming to OP setting, I would, in the patients who are stable, in those patients, then I switch to long-acting agents. Long-acting agents have lesser side effect profile when looking at when looking at tachycardia as compared to short-acting agents. Levosalbutamol has much more incidences of tachycardia, while if I see bilanterol is much more safer. Okay, and then I would, in the methylxanthine, if I have to use doxorubicin, is a different kind of methylxanthine, which doesn't exactly act by the same mechanism as aminophylline or theophylline or radiophylline. So that is considered to be more cardioprotective, but definitely not many studies are there on that proving that protectiveness. But theoretically, mechanism-wise, it is considered to be cardiosafe. So I choose to use doxycycline many times. Acebrophylline also helps. So switching the molecules helps in a patient where some molecule is causing problem. Switching the molecule helps. So like that it has to be managed.
And see one more doubt, ma'am. Like when we're using drugs like ipratropium, tiotropium, in that case, when we're using ipratropium, that is a long-acting drug. Uh, sorry, tiotropium is long-acting drug, right, ma'am? So in that, if we are getting again attacked in between, just we are giving once in a day. So attack, we can use the same drug in regular basis, ma'am.
Tiotropium is not a reliever or standalone control of medication. Okay. So tiotropium, you have to understand, is a long-acting antimuscarinic. It is an add-on therapy. So the treatment of GINA that I haven't touched in my presentation is in stepwise manner. Step 1, step 2, step 3, step 4. Wherever your patient lands according to the symptom burden, at that step you initiate the treatment. So tiotropium only comes after the patient is not being controlled on high dose ICS-LABA. So ICS-LABA is again divided into low, medium, and high dose. So if you are able to control the patient on low or medium dose, then you don't add tiotropium. So tiotropium or LAMA, any LAMA is added is recently been introduced in asthma. Previously, we were not using LAMA in asthma, but now it's being added. It is added for those patients who are not being able to control the high dose. So whenever you have tiotropium, that means you have ICS-LABA by default. That patient is on ICS-LABA, and tiotropium is not a reliever medication. It will not give, or even LAMA is not a reliever medication. It will not give. Uh, reliever effects as good as SABA. So, in reliever medication, we have either ICS formoterol, that is LABA, long-acting beta agonist, or we have ICS SABA, which is salbutamol or nivosalbutamol, those things. So, tiotropium is not used for that. Why you have asked about tiotropium is, or maybe ipratropium, is because we are using levosalbutamol ipratropium combination. Okay, we use that is the most common combination, is which is short acting and it is being used to relieve bronchospasm. So that is mainly for COPD, which was indicated. But yeah, by convention, that is the drug which is given most commonly whenever a patient reaches a hospital setting. But in asthma, as such, it is not, as per guidelines, indicated to give short acting SAMA also. But the combination works with this levosalbutamol and ipratropium both work at the level of smooth muscles. So they both work to decrease the smooth muscle constriction by different receptors. The beta agonist will act at the beta 2 receptors and this will act at the M2 receptor. So more drug, that means more receptors are available and the broncho spasm will get relieved better. So that is the idea of using the combination there. So that helps in relieving bronchospasm, but standalone LAMA or SAMA is not a reliever therapy.
Thank you so much, ma'am. Your presentation was very informative, and as an expression of our deep appreciation, we will present a short to you, ma'am. And I would request Dr. Alia, ma'am, Assistant Professor, Department of Amraze Niswa and Kabbalah, to kindly come on stage and present a short to our distinguished guest. Please, ma'am. A shawl is not merely a piece of fabric, it symbolizes warmth, respect, and gratitude. Now we have the privilege of presenting our guest with mementos. So I would like to request uh, Respected Dr. Tanveer Alam sir, Assistant Professor, Department of Kulliyat, please come upon the stage to present a memento to Dr. Swati ma'am. Uh, I would like to request our principal sir, medical superintendent of our hospital, uh, Janab Professor Tauhid Kibria sir, please come upon the stage to present a certificate to Dr. Swati ma'am. We learned a lot, and it looked we are in classroom. Thank you so much, ma'am. And most of the PG scholar asked that do you have any YouTube channel so that we can watch your videos?
Not as of now, but we are planning to start on. So stay tuned and we will do so. We will share with the competition.
Okay, ma'am. Thank you, ma'am. Thank you so much.
Thank you so much.
Thank you. Ma'am. Please have a seat. Ma'am. But as it is said, all good things must pause, just for a while. So our lecture will proceed after the lunch break. And before this pause, I would like to call respected sir, Dr. Shamim Akhtar sir. Please come upon the stage for the to end up and summarize the event till now.
अभी हमारा आप डॉक्टर अमृता स्वाति को सुन रहे थे और उनका टॉपिक था एज्मा एंड इट्स मिमिकर्स। बहुत ही तफसील के साथ उन्होंने अपनी गुफ्तगू को रखी। हम और आप जब इस तरह के मरीज़ को ट्रीट करते हैं, जब अपने क्लिनिक में होते हैं, तो जनरली जब भी इस तरह की तकलीफ़ को लेकर के, सांस फूलने की तकलीफ़ को लेकर के आता है, धड़ल्ले से हब्बे ज़िक्र नफस वगैरह लिख देते हैं। लेकिन नहीं, आपने सुना मैडम के लेक्चर को जो बहुत ही तफसील के साथ इन्होंने अभी डिलीवर किया है कि बहुत सारे इसके ट्रिगर फैक्टर्स हैं, बहुत सारे इसके प्रीडिस्पोजिंग फैक्टर्स हैं। इटियोपैथोजेनेसिस को भी आपने सुना, और जो थेरेपीज़ मॉडर्न मेडिसिन में है, रिलीवर, मॉडिफाइंग और जो भी प्रिवेंटिव एस्पेक्ट्स हैं, सबको आपने सुना। और फिर बहुत सारे जो मिमिकर्स थे, खासतौर से वोकल कॉर्ड डिस्फंक्शन, GERD, पोस्ट वायरल टसिव, हाइपरवेंटिलेशन, तो इन टॉपिक्स को भी हमें और आपको पढ़ने की ज़रूरत है, ताकि जब हम मैदान में जाएं, अपने क्लिनिक को एस्टेब्लिश करें, तो वहाँ मरीज़ को बहुत अच्छी तरह से ट्रीट कर सके। हमारे इस सिस्टम में इस मर्ज़ को दूर करने के लिए बहुत सारी दवाइयाँ हैं, जिनमें हम ख़ास तौर से हम लोग लिखा करते हैं असलसूस है, अड़ूसा है, जंजबील है, परसियाशा है, और इसी तरह से और भी दूसरी दवाइयाँ, तुफ़्म कता वगैरह है। इन्हीं के मुरक्कबात को हम और आप जब लिखते हैं, और ख़ास तौर से जब इस मर्ज़ का सबब बलगम की इफ़रात हो, तो उस वक्त काफ़ी कारगर साबित होता है और हम मरीज़ की तकलीफ़ को उस बहुत ही अच्छी तरह से इजाला कर लेते हैं। मुझे याद आ रहा है कि इसी कॉलेज के प्रिंसिपल, एक्स प्रिंसिपल प्रोफेसर शहाबुद्दीन साहब अक्सर बड़ी ही खूबसूरती के साथ और बहुत ही दिलचस्पी और इंटरेस्ट के साथ बयान क्या करते थे कि इस तरह के मरीज को सिर्फ आप स्वालिन लिख दीजिए तो मरीज ठीक हो जाएगा। और ये बहुत बड़ी सच्चाई और हकीकत है। स्वालिन के जो अज्जाए तरकीबी में जिन अद्विया की शमूलियत है वो सारे के सारे मुखरिज बलगम हैं, मुनफिस बलगम है और बहुत ही सस्ती दवाइयाँ और परचून की दुकान वाले भी इसको फरोख्त करते हैं। बहुत ही जायकेदार, बहुत ही लजीज। आपको भी थोड़ी मोड़ी अपर रेस्पिरेटरी इन्फेक्शन हो मुंह में लेकर चूसते रहिए और बच्चों को दे दीजिए टॉफ़ी के तौर पर, वो चूसते रहते हैं। तो हमारी मेडिसिन भी है, लेकिन हम सबको ज़रूरत क्या है, जब हम मरीज़ को ट्रीट करें तो प्रॉपर हिस्ट्री लें और जो एग्जामिनेशन है वो सब करने के बाद दवा को तजवीज़ करें। तो इंशाल्लाह हम और आप इस मर्ज़ के इलाज करने में बहुत ही अच्छा रोल अदा करेंगे। मैडम, मैं आपका कॉलेज की जानिब से, तमाम असातिज़ा की जानिब से बहुत बहुत शुक्रिया अदा करता हूँ कि आपने बहुत ही तफसील के साथ इस मौजू को हमारे तलबा के सामने रखा है।
Thank you, sir. Now this is the end. I kindly request you all to be back at we have more exciting session lined up for the second half. Please come back after the break. Thank you.
लो भाई, हेलो।
हमको नहीं चाहिए। आपके रिएक्शन
हम्म।
बहुत खूबसूरत गजल लिख रहा हूँ, तुम्हें देख कर आज कल लिख रहा हूँ। मार लगेगा।